And this is a really important statement. There's absolutely broad agreement that funding of services for male survivors should be in addition to and complementary to. It's not about competition, this. It's back to what I was saying about, you know, gender equality. Men and female survivors deserve equal and services and support. However, there is, it's urgently needed that we get the male survivor needs and support up the agenda, and certainly that is something that we're doing in Survivor Scotland. So I feel, because this isn't my kind of work, I'm kind of just going to kind of like take you through it to kind of hopefully give you a sense of it, because I think the scoping exercise is critical, and that's why Bob kindly asked me down today, and I meant to thank you at the beginning, Bob, because I think this is something that, again, it's telling us a lot of stuff that we knew, but it's telling us a lot of stuff we don't know, but it also means we've got it in black and white, because it's the next steps that's going to be really important of how we look at plugging gaps, making sure that services are developed to be centred towards male survivors. So Scottish Government funded Health in Mind, which is a mental health survivor agency. They work a lot with survivors. They've got a Beyond Trauma team, and to conduct this scoping exercise. So it really went out to all of the NHS boards in Scotland, all of the local authorities, the Scottish Prison Service, and the relevant and appropriate voluntary sector service were all approached to see what kind of services that were being provided. And that was obviously the eligibility criteria. Information was collected via the internet, telephone interviews, followed by more focused, you know, one-to-one sort of interviews on qualitative and quantitative data. And again, it's all in here. Again, the scope was psychological therapy services within the 14 NHS boards. Approximately 73 voluntary sector counselling providers, and again the specific local authority counselling services, and again counselling and psychotherapy within the Scottish Prison Services. So that was a kind of scope of who was approached. This is kind of really a bit repeating, actually, the slides that I've got here. That was just really, that first header is really more or less what I've just said. It's not. Oh. The other important thing that we were wanting to sort of like retrieve out of this scoping exercise was the training and awareness needs of staff relating to male survivor issues, working both in the voluntary and the statutory sectors who were delivering counselling. And again, it's interesting because training is one of the big, and awareness is one of the big kind of findings that's in the full report. And again, trying to kind of get, sort of identify gaps in service delivery and staff training. What came across, there was a huge disparity across the board areas on the ratio of staff to CSA survivors. I mean, again, most of it was actually happening in the voluntary sector. We kind of knew that. I mean, it's really most of the work with survivors is happening in the voluntary sector. Seeing here, generic service showed a similar lack of consistency, although the ratios improved. I don't really know what that is. This is a slide from Teal, my colleague. This is interesting. The waiting lists for the NHS services were an average of 17.3 weeks, whilst those for the voluntary organisation was 7.3 weeks. So that's interesting. I mean, that's again, and again at the thing we had on Tuesday, so it was interesting how quick the sort of like the turnaround for still seeing survivors, even though survivor agencies have got, you know, a huge demand on them, how they still will respond and meet with survivors in a short period of time. There was no figures around referral numbers to correlate this with evidence of demand. There's a lot of unanswered questions in this, but that's good because you know, that's when we need to then work to drill down and get answers to them. So the implications is that, generally speaking, NHS services take a significantly lower percentage and of local authority, voluntary sector and referrals in the voluntary organisations. And interestingly, for somebody who's managed a survivor agency, we always had huge referrals from the NHS, but no money. I'm very happy to refer, very not keen to fund. And I see a lot of nodding heads over there, so I know I'm on the right track. And that is about, you know, some of that may be to the requirement of funders, but I think there is something that we really need to look at, and if we're talking about care pathways, means of survivors to be able to negotiate and navigate their way through care, is that, and it was mentioned again today, is that we need to work across. All of the different disciplines need to work together. We need to join up our collective expertise, enthusiasm, and also, and this is for the people who actually matter, and that is the clients, patients, however you may wish to describe, is come to use our services. And there are a lot of things came out about stigma and CSA and mental health within this kind of these findings of how, you know, again, back to what we spoke about this morning, is that, you know, the survivors come through a mental health route, a mental illness model, as opposed to a trauma. And so again, we're looking at, again, rebranding, renaming, somehow reclaiming this whole experience to be something about trauma, cause and effect. There's a causal thing that ends up in this effect. And the presentation this morning, I thought, showed that very much. So we need to really look at how we kind of destigmatise. And I think the way forward is trauma. I'm not surprised because of just the kind of the way Scotland is kind of, you know, cities and towns and villages and huge areas of sort of rural, the huge disparity. I mean, in Fife, we've got an amazing situation. We've got CASP, we've got FRASAC, Fife Rape and Sexual Assault Centre for male and female adults who've been sexually assaulted, safe space. Fife and other areas in Scotland are well represented, but there's other areas that are really huge gaps. It's interesting that, you know, me reading this, because again, as I say, we just got it on Tuesday, there was little information or no information about levels of unmet need. I think we need to sort of, again, have some kind of dialogue to kind of find out what that's about. And then the question, a lot of the responses was, well, are we really sure about the statistics and the prevalence? Are we really sure about, you know, the level of demand? But yet, what was quite good in one other bit of the report I picked out this morning when I reread it, was that waiting lists are for male survivors and referrals are on the up, are on the increase. And I hope following this work and when we go to the next steps, that will you know, again, we'll start to explain why and help educate and inform. And again, it was acknowledged that the initial referral to counselling and psychotherapy may be for different presenting issues. There may be, you know, obviously we know substance misuse, alcohol, you know, what medical profession may be called dual diagnosis. So kind of drawing in conclusion, how referrals are accepted within the statutory and voluntary sector a process has implications for service accessibility. My experience, and I was saying to you last night when we were out for dinner, is that I felt that the male survivors who used our service felt more comfortable because they were coming to a non-statutory service. There was a great deal of fear of going to a GP and disclosing abuse because it may well be misinterpreted. This man wrongfully interpreted would be somehow a risk to his children or others. So a lot of men actually were kind of pleased to come to that, but we'll go on later on where there needs to be a range of services. Again, we need to look at this, the staffing levels and the waiting lists within the NHS, because a lot of survivors, when they go to their GP and do disclose, and the GP is sympathetic, they get put on a waiting list to see a psychologist or whatever. And the thing is, does that survivor need that particular route? They may well be on that waiting list for a period of time when it's actually not something that they require. So maybe there's something, again, how the style of the voluntary sector do work, is to offer the opportunity to explore what it is that you need. What is it that you feel that you need? Because most survivors at the point of disclosure just probably haven't a clue. And they need time and opportunity to be able to kind of, to arrive there, rather than us assume that this is what you're going to need. And my favourite quote, and Sue will laugh, is that, you know, not all survivors need 100 years of therapy. I worked with one male survivor who said, I just want this guy to stop living rent-free in my head, which is, to translate that is, I want this man, his perpetrator, to stop living rent-free in my head. And that's all he wanted. That was his therapeutic outcome. That's what he wanted. And he wanted it like a kind of almost unpacking this big box, have a look at it all, clean it and put it all back in, and then go away, never see me again. And that's fine. So again, it's about not assuming that, you know, referring on to specialist services or psychological and other services are necessary. So we need to investigate that. The negative impact on, I don't like the word negative impact, I wouldn't use that. I would say the fear and the kind of distress that it can invoke in staff is something that we are very well aware of and very mindful of, and have to be very you know, supportive to help bring our colleagues who have got great many skills to be able to realise, to get over the fear of working with survivors, that they're not going to explode in front of their very eyes, and that you know, and they'll also be respectful around boundaries as you negotiate them with them. And Sue and Sarah's book, Yes You Can, is an excellent example of that. I would recommend it. There's a copy lying there. We'll see if we can get more to you. And again, you know, so that is about support. And I did work in Fife with a psychological trauma forum and worked with nurses, and they would, and even a psychiatrist actually was jealous of the amount of clinical support and supervision we as counsellors and got. You know, one Joan Gallery, who's a psychiatrist, said, you know, God, I wish we got this level of clinical support. And so that's something we need to look at. So the value of specialist training and the lack of specialist training for generic services, the need for this flexible approach. I'm kind of at odds of repeating myself here with these slides, rather than one particular type of approach. So again, we need to explore that. But there has to be an organised structure as well. I mean, this can maybe look a bit too nebulous, but we know, but I think there still has to be. And I think maybe for men who are notoriously bad at accessing services anyway for their own health, we know this for their physical health needs and nothing else. And I've got one at home. I have to take him to the doctors, you know, to make sure he'll go. There is something there about being very flexible and finding ways. And as I was saying earlier, that, you know, the way that we learn as counsellors to work with male survivors is working with male survivors, because they train us, they help us, they inform us. And that's something we can look at there.